Hi everybody, welcome to the CBP nonprofit weekly video research presentations where yours truly, Dr. Deed Harrison, goes through each one of our peer-reviewed projects in a video presentation format. I try to go through the clinical background of it, and I try to make it clinically relevant for both patients and doctors. So hopefully you appreciate that and you enjoy these videos. I've been talking for the last few weeks about our research on head and neck translations left and right. This is really an underappreciated problem in all healthcare. The biomechanics of it, the stability of it, the pain and disability that patients can have with it, and really the health issues that people can have from it. So now what I'd like to do is go through a clinical case where we walk you through the application of the previous few weeks' information on these head and neck translations. Now I've chosen a rather difficult case. This is a peer-reviewed project that came out in 2010 out of the Journal of Vertebral Subluxation Research. Now this was done by my colleagues Marco Ferrucci, Abe Cardwell, and then myself. And this was actually a project that Marco did as a student at Life University. So one of the big chiropractic colleges down in the Atlanta, Georgia area. Okay, so he did this as part of a class that he had to, obviously take as a student, but then there was a peer-reviewed project that they got the option of doing. Go in and look at a chiropractor's patients and do a case report, write it up. Let's write up the patient history, let's write up the treatment, and let's write up the outcomes. Well, the professor that was teaching the class thought that this one was of such value and very well written that I got contacted and I got asked to help write this up for formal peer-reviewed publication. So I became like an advisor on the project, which is why I'm the last author on this. So it was really spearheaded by Marco, who is now a graduated chiropractor, so he's a doctor. He's on the East Coast. And then Abe Cardwell was a former chiropractic biophysics instructor at Life University and has a clinical practice down there. And this was actually one of Dr. Abe's patients. Okay, so let's read the title. The outcome of chiropractic biophysics or CBP technique protocol on a patient with Tourette Syndrome, Tardive Dyskinesia, Crest syndrome, and fatigue. These are really major issues. This is not simple pain and disability. Now, Tourette syndrome, some of you know, but some of you don't know. To truly be Tourette syndrome, you have to have this condition for typically more than a year. And there's different categories of Tourette's. There's what we call phonic, which is sound, or motor, which is movement, okay? There's both simple and complex in each one. Simple phonic would be like a grunt, a snort. Complex phonic would be vocalization of words. A lot of times it's profanity, right? So the favorite movie, Deuce Bigalow, put this in a humorous point of view. It's not funny, but at least they put a humorous twist on it. He took the young lady with Tourette's to the ball game and yelling out profanity, etc. That's a very complex type of Tourette's. This person didn't have the complex phonic, but had simple phonic, so sound verbalization or vocalization. And then the motor side of it is rapid movements, like you'll see grimaces or you'll see a twitch, tensing in the face muscles and the shoulder muscles. You can see that in the abdominal area down into the lower extremities. So it's a rapid twitch or tick movement that creates a involuntary contraction of the muscles. So the person doesn't have control over it. Now, if you've never been around people with Tourette's, you've probably seen them. And you know what? Sometimes they're embarrassed by this because everybody looks at them. But you know what? Hey, you don't get embarrassed if you have Tourette's. It's what you have. If this person's looking at you, just, tell them, hey, I got Tourette's. And you know what? If you watch this, if you see a person with Tourette's or you have Tourette's, why don't you consider going to a CBP chiropractor, because what I'm about to show you is going to blow your mind. These things, Tourette's, can be driven by a number of things. Number one, it could be drug-induced, okay? There are many reported cases that you got the tic or the Tourette's after medication. sometimes after vaccination, right? If you read the labels on it, they downplay it and they say, oh, it's only 1 in 16,000 or 1 in 50,000. Well, what if you're that one that got Tourette's from a vaccination? Not so great. Other times, it's a head and neck trauma. Other times, it can be, maybe it's not a drug, but it's a chemical that you got, into your body, right? In this day and age, we're exposed to many, many chemicals. So we can get a chemical-induced type of Tourette's, okay? Not quote-unquote drug, which is pretty much the same mechanism, pharmacological versus, an actual chemical being ingested in or breathed in. So then, what is tardive dyskinesia? Tardive dyskinesia is similar to Tourette's. This is a complex motor movement. Like if you watch my head, tardive dyskinesia is an involuntary gross motor movement. This is a very challenging thing to work with people. And sometimes it can be, very often, other times it can be not so often. In the ones that are very large and very frequent, these are difficult and challenging for the person to do or to deal with, right? So these are involuntary types of movements that it's not exactly the same as a tic, okay? Similar mechanisms are involved, but they are different disorders. And then we have Crest. Crest is a complex autoimmune disorder where you have many facets involved, okay? It's similar to scleroderm and different types of skin disorders, etc. But it's an autoimmune but environmentally triggered disorder. So you can get high stress or you can get chemical irritants that cause this. So the theme is actually all three of these are neurological disorders and they can have a similar origin. Obviously there might be a genetic component to this, but there certainly is an environmental component, whether it's chemicals that you came in contact with or it's a trauma that brings it out to the nervous system. So this patient is a 45-year-old male with these three things, right? If you look at his history, he's got a history of really bad problems, You put this in perspective, you look at somebody else, you go, whoa, look what they've dealt with. Hat goes out to these types of people. They're, dealt this certain card and you got to play that hand, you got to deal with it. But the good news is there can be a lot of things that can help these disorders and not just, taking drugs, right? So if you look at him, he's got irritable bowel syndrome as well, IBS. He's got neck pain, irritability, shortness of breath, diarrhea goes along with the IBS, cold hands and feet, carpal tunnel syndrome, low cortisol levels due to adrenal deficiency, leg calf Perth syndrome. When he was young, he had to be in a brace for the left hip because it's a disorder where the femoral head, the top of the femur head where it goes into the acetabulum, you injure the growth plate and you can have injury there, so you got to brace it and support it. And then when he got a little bit older, he was diagnosed with Tourette Syndrome when he was given ORAP and Haldol for the tardive dyskinesia. Now, if you look up these medications, they're a nervous system or motor neuron depressant. So they shut down the excitability of the motor neuron area. Well, that also shuts down all excitability. Anybody that's taken this medication, you know what I'm talking about. This is a serious issue. In a male, many times this can lead to male impotence. And so if you're a male, no matter how old you are, this is a devastating thing. This is a problem. And this can be medication-induced impotence. Not a fun thing to deal with. Many times males and females, we don't appreciate the condition that each other is going through. You have to be of that gender to really understand this. So you got to realize the major life impact that this issue can have on a person, right? Okay, now, also, this individual was receiving injections and electrophoresis. The injections, like Botox injections and electrophoresis, this is also trying to inhibit the motor neuron pool, and it's trying to stop these involuntary muscle movements in Tourette's and the tardive dyskinesia. Okay? Of interest, it didn't really work. Okay, so this guy's on a lot of things. So now I've got to take my x-rays And we've got to see, is he a candidate for these types of procedures? Our mirror image exercise, mirror image adjusting, and mirror image traction. Now shown here is a simple version of that for a simple head translation. So we look at his posture and we go, whoa, it's a little more complex. Let's see what the x-ray looks like. So here's the actual x-ray of the person. Now I showed this x-ray last week and I told you that 31 millimeters was at its end range of motion. This is how far the average person can maximally move when they try to maximally move themselves. We did that in last week's research project out of clinical biomechanics in the year 2000. Now this is a person that has 31 millimeters stuck in their neutral position. That's severe. It's a very, very large, gross postural displacement. By gross, I mean it's obvious, it's large. And then we take the x-ray and we see these big angles, a 20-degree mid-neck angle. I really only want to see it at about 14 to 15 degrees at most, right? And then a 16-degree upper back angle. I don't want to see it that large. Okay, these are very large angles for a simple translation. What it actually means is there is a large translation, but there's something else going on. So we look at his posture, and shown in the skeletal animations are the postures that we're seeing in the person. Okay? There was a lateral bend of the head and neck, a tilt towards the opposite side of the translation. Okay? And I should tell you that the x-ray is shown as looking at the person from behind. That's why the R is up here. That means that's his right side. So you're looking at his back. Okay? The animation is shown as looking at from the front. Okay? So the right side over here matches the right side here. So he's shifted or translated to the right, but he's tilted back to the left. He's also turned to the left. Okay? That's why we see a much more complex pattern in his neck than a simple translation. The other thing is we have a rib cage or a thoracic posture in this case. Look at the shoulder. Look at the right shoulder here versus the left shoulder area. You can see a very large tilt in the upper thoracic spine, and he's tilted towards his left side. This means that the head and neck posture of the bend is very large. Look how close his ear would be to this shoulder versus the ear to this shoulder. These are very large postural displacements. Okay? And then there's another one. He's turned in the rib cage. How do we know that? Well, I start to look at the clavicle or shoulder girdle area here, and I can see that the clavicle is closer to this part of his vertebra on the left side versus the clavicle over here on the right side. So I know he's twisted. So this guy has such large postures, and he's got tardive dyskinesia, so he's moving during the x-ray. What happened was the radiographer did the best they could under the circumstances, but accidentally allowed this posture of the ribcage rotation to be in when they took the x-ray. So we see some of this rotation showing up in the spinous processes of the vertebra. So if you're a doctor, that explains some of the things that we're looking at. Still, that being said, this is a very large spine displacement. How large? You don't typically see them this large. This is like in the 1% group. If 100 people came in, the chances are that you wouldn't even see 1 out of 100 look this large. I'm telling you that right now. This is an extremely large problem. And you look at this and you go, how is it possible that all these doctors missed this? Look at all the doctors he went to. How is it possible that you just drug somebody and put them on medication when their head is so far off? I don't understand. I honestly don't. You look at this and you go, he's been to probably 50 different doctors, and nobody got it until he went to Dr. Abe Cardwell, right? Serious issue. So what do? Well, we try our best to work with them and do mirror image exercises, mirror image adjusting, and mirror image traction. It's not a simple movement. It's got to be combined movement because we have multiple postures, right? So he's translated way to the right, so we got to translate the head to the left. We've got to bend his head to the right because he's bent to the left. We've got to turn the head to the right because he was turned to the left. So what we're showing is how we would do that on an adjusting table. Okay, now it is safe, but we do have to be careful because these large movements, what happens is if I'm not careful, I can, contact the jaw area accidentally. So I have to make sure that, I'm a trained chiropractor, I know what I'm doing, and our doctors that do this work, they're trained. This is the things that we teach them. They learn this in chiropractic college as well, but we also teach this in postgraduate courses to our doctors. So we're going to be careful, but we're going to work on all three of those head postures at the same time. And then we're going to reverse the thoracic postures. The thoracic postures, we're going to bend to the left because he's bent to the right. We're going to turn him to the left because he's turned to the right. So shown is an adjustment for the posture. We call these mirror image adjustments. We're going to do this every single day with him. This is not going to be done once. It's not going to be done once a week. It's going to be done every day that he comes in. This case needs it every single day of the week. We'll give him Saturday or Sunday off because typically most offices aren't open. But he's going to be treated every day. Then we're going to do the exercise. Mirror image exercise, where we're going to translate you with your body movement. Your muscles are going to do this. So you got to learn how to pull the head to the left, tip the head to the right, and turn it. Stephanie's showing this. She's really good at doing these movements. Patients at first have a hard time with this, especially somebody like this that has the complex disorders that he has and the large postures. But we're going to work him through it. He's going to do this every day. He's going to do it in the office and he's going to do it at home. And then when we need, we'll add resistance to it. You can see how fun that looks for Stephanie. You know what? Is it a little uncomfortable? Yeah, it's a little uncomfortable. But so is Tourette's, right? So is Tardive Dyskinesia. So is taking medication that depresses your body's nervous system, right? So a little bit of discomfort, that's probably acceptable as you're going through rehabilitation, right? You need to change your perspective. Some people go, well, it's a little uncomfortable. Well, really? Do you want Tourette's and Tardive Dyskinesia for the rest of your life? Or do you want to go through a little bit of discomfort to get to where you want to be? Okay? And then that leads us to the one that probably is a little more discomfort. This is called traction. This is where we're going to have to hold the head and neck as far as a patient comfortably can and bend that angle out of there. This guy's angle is so large at the mid-neck and his head and neck posture are so large, the adjusting and exercise alone is not going to change it. Let me repeat that. It's not going to change it. You're going to have to add traction. Traction is where we physically force your body to move into its opposite position and then hold it there for a period of time. 5 to 10 minutes is usually adequate. Now, this is not on the jaw. It's on the neck. And we always go to patient tolerance, right? So if you look at this and you go, oh, that's like medieval torture. Well, no, not exactly, because you can tap out, right? And there's little hooks and levers here that you can release it yourself. And it's always at the patient tolerance, okay? So this is what it takes. You're going to load the soft tissues and neck over, and over time, your spine's going to change. Now, this guy received over 80 treatments, okay? 80 treatments. It's not 36 or 40 in this case like typically we would do. His head and neck posture is so large that he's going to need more. So we got over 80 sessions with him. Let's look at the outcome. This is true before and afters. Now the before is when he, first exam, analysis, and x-ray. That's what he looks like. The after, we're going to give him 80 some sessions, and then you stop care, and then in a minimum of 1 day and up to 3 days later, we re-examine you. So we don't x-ray you right after the treatment. That's cheating. It will look better right after the treatment. But you wait a minimum of a day with doing nothing, and then you see what the results are. Look at this change. The 31 millimeters went down to 6 millimeters. That's huge. The 20-degree angle down to 8.5. The 16-degree angle down to 5. This is a huge change. Right? Yeah, it took 80 sessions, but you know what? That's a lot longer than 40 years, which is how long he was likely stuck like this, right? So 80 treatment sessions in a compact period of time, like 6 months, well worth it for this guy, well worth it. Now, what were the results? The results were remarkable, remarkable. All these neurological conditions dramatically improved, so much so that the medication was able to be terminated by the patient and the medical doctor on the case. Okay, so chiropractors, we don't use medication. We're not licensed for that. And quite frankly, most of us don't want you to do medications, right? They're there for people that absolutely have to. So when we see a patient that is experiencing dramatic results under our care, what we'll say is, why don't you make an appointment with your medical doctor and talk to them about what you're doing and how you're feeling, and see if your medication can be tapered down, or maybe your medical doctor thinks you can even stop, right? And of interest in this case, the patient's medical doctor and the patient, the results were so profound, they were able to stop medication usage for these conditions. What a deal, right? What's the life impact for this in this person's case? The life impact is huge. You're giving this person their life back. Their Tourette's goes into remission. Their Tardive Dyskinesia stops. You know, if you're this person, and it's terrible that I'm even going to say this, but you know what? I've worked with enough patients like this. I know how they feel. You feel like, oh my God, somebody's watching me all the time. Everybody's looking at me. They think I'm, some kind of weirdo. You're not a weirdo. And the people that are looking at you, they should stop looking at you. What they should do is come up and say hi to you. How you doing? And then if they've seen this video, they should say, hey, you know what? I know that there's some things you've probably tried, but there's probably this stuff that you haven't tried, chiropractic BioPhysics, where you correct your neck, right? So there's two sides of that. If you're going through this, don't be embarrassed about your condition. It's something you can't help, right? So screw everybody else, how they're looking at you. That's the reality of it, right? Conclusions. The reductions of the patient's abnormal posture and spine radiographic displacement in the head and neck using CBP care may have been responsible for improved neurological issues such as Tourette's, Tardive Dyskinesia, Crest syndrome, fatigue. Now, look at the way we had to word that. When you do a journal publication, you can't write, we cured it. You can't say, doing this cured it. You don't have proof because you didn't take that same person and over the same exact time not do it to them, correct them, and then that same person and do it to them. So you don't, 100% truly from a research perspective, you don't know, well, maybe it just went away on its own in 6 months. So when you write a peer-reviewed paper, the researcher, we have to go, it appears to be correlated to what we did with spine correction, that his symptoms spontaneously remissed. But the clinician in me, the real person, goes, of course we did it. He had it for 40 years, and before he did this, it didn't get better. So of course the treatment is the thing that cured it, right? You guys get it? But the way the paper has to be written, you can't write that. So there's two sides of this, So if you're a patient out there, you go, oh, well, it may have been responsible. Well, if you ask the patient, he'll tell you, it was absolutely responsible for improving his neurological conditions. But from the research paper perspective, you have to temper that down, right? All right, so this is this week's presentation relating head and neck translations and, very large displacement in this case to a patient's health and disability, right? This is a really serious issue for people out there. This is not simple neck pain and simple disability. This is really, truly affecting somebody's life and quality of life. If you've got these conditions, absolutely you should seek out a CBP-trained chiropractor. Not always will it work for you, but if you're like this, if you have large head and neck displacements, I'm here to tell you that is not good for your nervous system. That puts mechanical pressures on your nervous system, and when you do that, it doesn't work right. Your spine is your lifeline for your nervous system. Your nervous system controls everything in the body. Everything in the body talks to each other through the nervous system. If your spine is screwed up, that's the highway, then your nervous system is going to be screwed up. You got to get your spine corrected for optimized health. And maybe, just maybe, you'll have results like this patient here. So hopefully you enjoyed that. I'm Dr. Deed Harrison. Until next week, enjoy your week. Thank you. If you like this information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy to use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work. Okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up. Enjoy your week. Thank you.